Hello everyone, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, feel free to type in your questions at any time. However, please note that all questions will be reserved until the end of the webinar. We have allotted enough time as possible to answer as many questions as we can. Today's webinar update on the management of Cushing's disease is being presented by Dr. Nathan Zwagerman. Dr. Zwagerman is the Director of Pituitary and Skull Surgery and a Professor of Neurosurgery at the Medical College of Wisconsin. He did his undergraduate work in psychology at Calvin College in Grand Rapids, Michigan. He earned his medical degree at Wayne State University in Detroit. He did his fellowship in endoscopic and open cranial-based surgery and then his residency in neurological surgery at the University of Pittsburgh Medical Center. Dr. Zwagerman, thank you so much for your involvement in the PNA's webinar program. And there's going to be a brief delay as we change presenters. And you should see on your end to accept.
Got it.
Okay, I can see your screen and I can hear you.
Perfect.
It's all yours.
Fantastic. Good. I appreciate it. Thank you so much for helping put this all together, and to the PNA for allowing me to talk about a topic that I'm passionate about and that we here in Wisconsin often discuss, and I'm glad I get to discuss this with all of you. Hopefully you guys learn something out of this as a whole. One of the things that I talk about up front is I have no disclosures to talk about. And when we talk about Cushing's disease, it's kind of a vague entity that some people understand quite clearly, but at the same time it can overlap some other conditions. And so today we'll talk about the problem, how we diagnose Cushing's disease specifically, how we treat it, and if our first treatments or second treatments don't work, what other options are available for us. And so bear with me as we go through all of this. When we talk about Cushing's disease, it's really under the umbrella of Cushing's syndrome. Cushing's syndrome is a disease entity where we have supraphysiological levels of the chemical cortisol, which our body needs, circulating. And under normal circumstances, the hypothalamus produces a hormone that goes down to the pituitary gland. The pituitary gland then releases another hormone that goes to the adrenal glands. And the adrenal glands then produce cortisol. Cortisol then provides a negative feedback loop to both the pituitary and the hypothalamus to downregulate the production, so it's able to control itself. Here you can see in this image of the brain here, where the hypothalamus produces the CRH, goes to the anterior pituitary gland, which produces ACTH, which circulates in the blood to the kidneys and adrenal glands, and the adrenal glands produces the cortisol. In Cushing's disease, however, this whole axis is disrupted, and we'll talk about that more as we go forward, but in general, the hypothalamus produces the chemical it's supposed to, CRH, which then goes to the pituitary gland, but in the Cushing's disease state, there is a pituitary tumor there that's making the ACTH, and this produces more ACTH than usual, and that goes to the adrenal gland, and the adrenal gland then produces more cortisol than usual, but the negative feedback loop is broken. And I'll explain that more later as we go on. Cushing's syndrome is a collection of symptoms that people and signs that people experience that many of us have seen before, either as patients or as physicians treating them. A lot of it has to do with the excess production of cortisol, which produces fat storage, so people get the moon face or the fat pads, buffalo humps. People can often get easy bruising or abdominal striae or red streaks across the abdomen or underneath the armpits. People get usually this round red face that is very noticeable. People get central obesity, so their arms and their legs are thin, but their body is bigger. They can grow hair on their face and their chin when there shouldn't be hair there, especially in women. Women's hair can get thinned out and balding. People often are fatigued. The syndrome can be associated with vision changes. Menstrual disorders are common. In fact, one of the patients we recently treated was diagnosed because she was unable to get pregnant, and once we took care of her, that actually improved and she was able to carry to term. The effects of cortisol long-term cause high blood pressure and poor wound healing, associated with diabetes and mood and depression. And these people who suffer from this condition can be quite debilitated by their overall condition because of the collection of all these symptoms that occur. Cushing's disease is under the umbrella of Cushing's syndrome. Cushing's disease is a specific entity where we talk about a pituitary tumor that's producing ACTH that's then causing the adrenal glands to oversecrete cortisol. Most of Cushing's syndrome is related to Cushing's disease. Depending on who you read, it could be 70 to 80%. And the tumor in the pituitary gland is a benign tumor. It's an adenoma, so it's making a hormone. There's nothing we can do to prevent or cause this to occur. These are results of somatic mutations that occur randomly. In most cases, the cells of this particular tumor make a hormone called adrenocorticotropic hormone, or ACTH for short. Cushing's disease is relatively rare in the scope of the world, 10 to 15 cases per million, more frequently in women. They usually occur in middle-aged adults, but they can also occur in children and in the elderly. It's only a small portion of pituitary tumors, and most of them are less than 5 millimeters in size and presentation because of all the symptoms that people associate with it. So frequently we don't see these on pictures. And up to 10% may extend above the cella, and that may cause other kinds of problems, including vision changes as it presses on the optic chiasm above. A little information on ACTH itself. It circulates in the blood, it stimulates the adrenal glands to produce cortisol and other hormones that are in life at all stages. However, excessive cortisol can lead to the symptoms that we talked about earlier. Normally, I said the brain senses these excessive cortisol levels and works to provide a negative feedback to regulate the production of this, but in cases where the tumors or other kinds of things, that negative feedback doesn't work, and that's where we get into trouble, where we see these problems. Again, here's the normal loop, and here's the loop in cortisol disease, where you actually have only a small CRH because there's a negative inhibition on that. However, the tumor itself is still producing a lot of ACTH going to the adrenal glands. The first thing we have to see a patient with these symptoms is try to figure out, is this truly Cushing's syndrome or something else? And there are 3 laws that are commonly used to figure this out. The first one is the 24-hour urine. We collect urine over 24 hours and check the levels of cortisol. Most people have levels less than 50. You can see in my patient up here that their levels are actually greater than 100, indicating that they have excessive cortisol in the system. The next test is the low dexamethasone suppression test. It's fairly accurate for diagnosing Cushing's syndrome as a whole. Most people, when they get a steroid by mouth, and that's what we're giving dexamethasone, suppress their normal production, because that's the negative feedback loop. When your brain senses that you have the hormone, the brain produces less of it. So most people suppress. However, with a low dose of dex, pituitary hormones and pituitary tumors that secrete ACTH, or as well as other parts of the body that are making cortisol, will not suppress. And so that's one of the ways we can sort out if you're having excess cortisol because of something that's going on in your body. Finally, late night salivary cortisol test is fairly common. It's fairly easy to do. It's fairly accurate for cortisol Cushing's syndrome. The collection time is between 11 p.m. and 12 a.m. Most people's cortisol levels are quite low, and when they're above their recommended level, that usually means they have excessive cortisol. So you can see in this other patient down here that they have 3 straight salivary cortisols that are above the normal limits for the test in our area. And so once we have the diagnosis of Cushing's syndrome, figuring out whether a patient has Cushing's disease can actually be quite hard. And the reason for that is there's a lot of reasons for Cushing's syndrome. Some of that could be iatrogenic, or the doctors can cause it by giving medications. Cushing's syndrome could be caused by other types of tumors that can cause secretion of ACTH as well, and that includes lung cancers or islet cancers that can cause excessive ACTH secretion that, again, stimulates the adrenal gland to produce the excessive cortisol. The adrenal gland itself can have tumors of it that make excessive cortisol independent of any other stimulation. There are a couple of familiar Cushing syndromes as well that are associated with excessive ACTH secretion or cortisol production, and you can see them here. And for the extent of this talk, we won't talk much about them at this point. Some of the tests we use to differentiate a pituitary source versus an adrenal source or other source from in the form of Cushing syndrome to distinguish if there's Cushing's disease is the high dose suppression test. And that suppression test is a test of dexamethasone where we give a high dose, and under high doses, pituitary hormones and specifically the ACTH secreting hormones will suppress under that kind of stress because there is some mechanism for negative feedback there. Under situations where the cortisol levels do not suppress, those are conditions where you have cortisol production independent of ACTH, and those make us look for other sources outside the pituitary gland. Of course, an MRI is useful to help sort some of this out. MRIs look at the pituitary gland. It can oftentimes find tumors. The problem is that with Cushing's disease, the pituitary tumors are quite small, oftentimes less than 5 millimeters, and they may not be picked up by standard MRI imaging. Special sequences have been shown to help. There's FLAIR sequences that can help differentiate different grades within the pituitary gland itself to help small tumors. Dynamic imaging, where you give a patient contrast dye and they scan the head several times over a period of minutes to sort out if there's different textures or different uptake of the contrast material within the pituitary gland. Finally, there's recent work that was done at Ohio State where they did studying, and they noticed that ACTH secreting tumors were more avidly picking up glucose. And if you label that glucose with a radio tracer, you can actually see that on PET studies, which can be helpful to sort that out as well. Again, most people, or half the people who have Cushing's disease, will have a normal MRI. And so that means that they don't see any tumor on that pictures. And more importantly, and this is interesting as well, up to 10% of people who have Cushing's disease may have an incidental tumor as well. And so just because the patient has a pituitary tumor on imaging and Cushing's syndrome does not mean they have Cushing's disease necessarily, because the portion of patients who have Cushing's disease is only a small fraction of the number of people who have pituitary tumors themselves. One of the things that we're working at here and elsewhere in the country is updating our imaging to get more high definition pictures. You can see in the standard 1.5 Tesla MRI here that really looks relatively normal, but on the more precise 7 Tesla MRI, you can start to see that there's a tumor here actually, and we're using these modalities to help us find where tumors are. And you'll understand in a little bit why finding the location of the tumor really makes a difference in the overall outcome of patients when they go to surgery. One of the tests that we've utilized here as well is the vasopressin desmopressin stimulation test, where we give DDAVP, which tends to induce ACTH and cortisol rise in patients who have Cushing's disease, but not in other pseudo-Cushing's kind of states. So it can help us differentiate Cushing's disease versus other causes for Cushing's syndrome. What we find is that the rise in peak cortisol levels up to 150 above standard, and it's relatively accurate for diagnosing this entity and helping us to localize where the source of the problem is. Of course, in the situations where we still can't find the answer, there is a test called inferior petrosal sinus sampling. This is an invasive test. It's been around for a while, and it's used when we really can't tell if the source of the patient's problem is coming from the pituitary gland versus elsewhere. Its range of sensitivities, specificities range depending on who's doing it and how often they're doing it in their X-ray level. But it can also help to lateralize the location of where the tumor is within the pituitary gland, which again is very useful when it comes to surgery, and we'll explain that more in the future. The technique is relatively straightforward from a thought process process. We enter the venous access, we enter through either the arm or the leg, and we advance catheters into the inferior petrosal sinus. Why the inferior petrosal sinus? We do that because the pituitary gland sends out its hormones into the cavernous sinus, which drains into the inferior petrosal sinus. And so we have almost a direct connection to the pituitary gland from these sinuses. You have one on either side, and depending on the concentrations of ACTH, which will be elevated in this area at baseline because it's so close to the pituitary gland and not diluted by the other blood products, we can get an accurate evaluation of if the pituitary gland is making excess of hormone, and sometimes what side that's coming from. When the catheters are in place, we give the patient stimulation in the form of CRH, which helps the pituitary gland to produce more ACTH, and this gives us a bigger bang for our buck to help differentiate where everything is, and to help us for sure to detect where the ACTH is coming from. Here you can see it dye injected into the inferior petrosal sinus, and it's going up to the cavernous sinus and surrounding the pituitary gland as well. Once we do the test, we get a report similar to the one we see here, where we get a baseline test from periphery right and left, and you can see here that we check baseline levels before we give the medications, at 0 minutes when we give medications, and then several minutes afterwards at different time frames. And you can see based on these evaluations that this patient appears to have a left-sided lesion that's significantly increasing the amount of ACTH that's coming out of the pituitary gland itself. And we can use that information to diagnose that the pituitary is the source of the problem, but also lateralize this to most likely being on the left. Of course, IPSS can't always be done. There are conditions that prohibit us from proceeding. Bleeding disorders, this is an invasive test where we access the venous system and we drain to get there, we create a hole in the vein that can cause bleeding down the road. People who have allergies to contrast dye can cause anaphylaxis, and so those are the patients who we don't do this test on, people who have ischemic heart disease or people that can't lay flat. Those are all reasons for us to avoid doing this test if possible. Again, nothing is free. IPSS has complications. The most common complication is a hematoma in the area where they access the vein. That can be up to 3 to 4%, not significantly high, but it can be provide some morbidity. These hematomas can be large enough where they actually have to evacuate them, although that's rare. Because we're giving contrast dye during the procedure to get to where we have to get to place the catheters in the inferior petrosal sinus, people can get kidney injury from the contrast dye. And because we're accessing vessels that are coming from the brain, there are risks associated with that, including pulmonary embolism, subarachnoid hemorrhage, and venous stroke, because we have a catheter in a venous plexus, and that can cause a blood clot to form around that. A venous stroke in the brain can cause a significant morbidity, including cranial nerve palsy and even hydrocephalus. Other things that we worry about with IPSS include radiation exposure. Because we have to give blood thinners to prevent the strokes, some people get a reaction to the blood thinners, and that can cause a platelet dysfunction. And of course, anytime you access the skin, you can cause an infection. So this is a flow chart that we follow when it comes to patients who have this syndrome. Obviously, the first thing is to diagnose whether or not they actually have Cushing's, and then we do the tests to do that. If that's abnormal, the patient has Cushing's syndrome, and then we check ACTH levels to determine if this is ACTH dependent or independent. Independent sources usually come from the adrenal glands. ACTH dependent sources can come from the pituitary or other source, and then we do those tests we talked about to sort out whether or not it's from the pituitary gland. If it looks like it's coming from the pituitary, then we go down one set of roads. If it looks like it's not coming from the pituitary, we go down another set of roads to try to diagnose this. And then finally, if we just don't know, inferior petrosal sinus sampling can be extremely helpful to sort this out. And so the treatment of Cushing's disease is obviously important, but whenever we treat a disease, we should ask, why are we doing this? And the short answer is that Cushing's disease ends lives early because of the morbidity associated with high blood pressure, diabetes, obesity, chronic wounds, and non-healing wounds can lead to infections. And so it leads to significant problems that require treatment for it. The question now is how to treat this entity. When it comes to treatment of Cushing's disease, the current model is that surgical resection of the tumor is the optimum treatment. It can provide the best chance of a cure if the tumor is found. And I think that's the key to this, is everything we're doing is try to help us locate where these tumors are found, because that allows us the best chance to cure the patient. Our practice is that we follow post-operative cortisol and ACTH every 2 hours for the hospitalization. Usually we found that if we cured the patient, the cortisol and ACTH levels crash within 48 hours. Our goal serum cortisol is less than 3 micrograms per deciliter. Once the patient reaches this level, they're often very uncomfortable. They complain of headaches, abdominal pains, nausea, vomiting, muscle aches, and just generally feel poorly. I liken this to having the flu, and that's how patients describe it to me. They just don't feel well. Once we get to this level, we initiate steroid treatment because these patients are at high risk for adrenal insufficiency. Because of the constant negative feed in the hypothalamus and the pituitary gland, the patient's natural ability to produce ACTH is driven down, and it takes time for that to build back up. The best opportunity for cure and salvation of pituitary function is surgery at this point, and the best chance for a surgical cure is the first operation. After the first operation, scarring will occur, and that may pocket some of those tumors in areas that you may not be able to see very clearly. And so it's really important for patients who have confirmed pituitary Cushing's disease that they seek out a surgeon who is comfortable and knowledgeable in the disease entity and knows how to treat this from a surgical perspective. There's a paper that came out that talked about something called Pituitary Centers of Excellence, and what these are comprehensive state-of-the-art facilities where they provide training to other people to help treat pituitary disorders, and they contribute to the research of the field, and they help to increase our knowledge of this entity to help us to get a better idea how to treat these patients and how to improve their quality of life afterwards. Again, they're characterized by great outcomes, great quality, and patient satisfaction metrics. To get to that entity, it really requires a team-based approach, and the team-based approach has several advantages and disadvantages. Different vantage points are one of the biggest things that we talk about here in our institution, is that everyone comes from a different perspective, and you get more eyes on the ball, so to speak, to help us figure out what exactly is going on and to address problems before or during their occurrence. Different priorities and different concerns are things that people have. When it comes to pituitary tumors, we don't take them all out through the nose, and I work with an ear, nose, and throat physician, and sometimes getting more exposure may cause more morbidity to the patient's nose, and those are different concerns that we have, and we can work together to sort that out. When you're dealing with problems, having different ideas is often helpful to provide a better solution, and you're having different eyes looking at the problems through different vantage points, again, to get you a better idea of how to deal with these situations as they occur. Of course, there are disadvantages to working with a team. Of course, organization can be a problem, especially when you have a large team, because there's different people that want to get their voices heard. So having a good organizational structure is important for that. People will have conflicting priorities when it comes to dealing with pituitary tumors, whether or not they want to protect the nose, pituitary gland, or get the tumor out. Obviously, that's a conversation, and I think that can sometimes get in the way of optimal patient care. And obviously, there's a learning curve when people work together, unless they work together commonly and frequently. Sometimes it takes a while to get on pace with each other to provide optimal care associated with that. And this theory of teamwork in skull-based surgery has been used and has been evaluated and is really shown to provide better outcomes, I think, in the long haul. And that for those reasons, a lot of centers are now transitioning to this team-based approach. This is my team here. My team consists of endocrinologists. There are two major ones that I work with, and they follow our patients all the way through pre-op, during the hospital stay, and then post-op. I have an inpatient endocrine team that follows every one of my pituitary patients with a pituitary focus. And so these endocrinologists obviously know the pituitary gland inside and out, and you can help us deal with the patients as they go through this process. I deal with ear, nose, and throat physicians who are trained in skull-based and rhinology to help us deal with wound healing and making sure that the procedures we do don't cause lasting harm in the patient's structure of the nose and don't cause further complications. Neurointerventional radiology is here in full house, and I think that's really important, because they can help with the diagnostic testing in the form of IPSS, but in case something happens during the surgery, they're immediately able to help address the problems. If surgery doesn't work, sometimes radiation is needed, and we have radiation oncologists that are part of our team to discuss these cases. A good pathologist to help determine whether or not tumor exists in the sample you send them can be critical, especially when you're dealing with microadenomas and you're not seeing it on the pictures or intraoperatively. And then finally, I have a team of nursing staff and nursing assistants that are critical in understanding this disease, and they understand the patients that come in, and they are extremely helpful to help the patients go through this process as they're familiar with the disease entity and how things transition into and out of the care. And so I can't be more grateful than I am for my team that helps us take care of pituitary and Cushing's patients. Again, Cushing's disease, statement about a neurosurgeon. Obviously, neurosurgery to practice independently, you get a complete residency, but having a fellowship training in pituitary surgery is also important, because Cushing's disease and treating Cushing's disease patients is more complex than a lot of other kinds of things we do. And unless you do a lot of it, the experience you need to do a really good job just doesn't tend to pan out. I think working at a high recognized volume of pituitaries indicates that you're doing this on a regular basis, and so that also contributes to better outcome. And of course, contributing to the pituitary research is important as we learn more about this disease entity and better ways to treat it from a surgical standpoint. And what we've learned is that experienced surgeons have better outcomes. They've seen a lot more, they're more experienced, and they have dealt with more situations. And because of that, they have better instincts and tend to have better outcomes from that perspective. And based on the statement, the ideal number of surgeries for a pituitary surgeon is about 50 a year. And I think that bears out in the literature that the centers that are doing a lot of pituitary surgery tend to have better outcomes. When it comes to surgery for pituitary diseases and Cushing's disease, our techniques of surgery have evolved along with our understanding of the disease and the disease process. There was a time when microscopic pituitary surgery was done, still is done in a lot of centers, and they're very good at it. But the advantage of the endoscope is that we can provide an expanded view of the sella and the pituitary gland, and that allows us to get better visualization in a lot of cases, especially when you have tumors that aren't behaving normally and are expanding outside of the sella. It's important to have a wide grasp of knowledge of pituitary and Cushing's disease, because you never know when you're going to have a patient presents with a tumor like this that's invading into the nose as well as supracellularly and surrounding blood vessels, versus a patient like this who also has Cushing's disease, but you can't see the tumor on the imaging itself. On top of that, you may have entities where the tumor is invading outside the cell behind important blood vessels like the carotid artery, or they may go above or between the carotid arteries that in most cases have historically been non-operable. But based on our knowledge and our work and understanding this area in detail, we know that this is not an inoperable place, and that sometimes these patients can have really good outcomes. Again, tumor in compartments of the cavernous sinus around the carotid artery that historically have been thought to be inoperable are now becoming accessible to us. And so this is a simple case that demonstrates a lot of these principles. This is a pituitary case of a patient who has Cushing's disease. She was quite symptomatic. She was diagnosed with imaging and all the tests that we talked about ahead of time. Before you saw us there removing the lining of the nose called the mucosa. Here we're taking a high-speed drill to drill off the bone over top of the sella. You can see the dura there. Here we're exploring into the cavernous sinus down low here. This is the carotid artery here going down. The cavernous sinus is in this area here. This tumor lateralized to that side. For that reason, we're getting more extensive exposure there. You can see the blue here of the cavernous sinus. We want to make sure we get access to that in case this tumor is invading the cavernous sinus space on the pictures. We do a wide exposure for functional tumors to make sure we don't miss anything. Here we're opening the lining of the brain called the dura to expose the pituitary gland. We're dissecting the lining of the brain away from the pituitary gland itself to get more exposure. Again, seeing the tumor is critical for the outcome of this case, and so we get a wide exposure. And here you can begin to see that there's something different about this part right here versus this part right here. And this is the tumor over here. You can see the discoloration, the normal pituitary gland is yellow. Here we're dissecting normal pituitary gland away from the tumor, trying to keep the capsule of the tumor intact so that we know when we get it out, we can get the whole thing out, leaving bits and pieces behind in the pituitary gland. We're dissecting the gland away here, utilizing all our visualization to make sure we get that. You can start to see the tumor going around. We're getting around the medial aspect of it by just dissecting in that plane that the tumor has already created for us. And just freeing it up, working around it circumferentially, trying to get this out. You can see that on this side, this in the cavernous sinus, this is the medial wall of the cavernous sinus. This tumor is clearly touching the medial wall, and data supports the idea that if it's touching the medial wall, there likely is some invasion. That's a common place for tumor reoccurrence. Again, just slowly dissecting around where the tumor is, trying not to break into it, trying to preserve the planes for best possible outcome for this. Further dissection around it, we're starting to get on top of it now, separating the normal pituitary gland from the tumor itself. Ultimately, we're able to take out the tumor, and you can see the normal planes of pituitary gland there. Here we're looking around, making sure that there's no signs of obvious tumor remaining, just double checking to make sure that we get every last bit. Here we're cutting the medial cavernous sinus wall where it was in contact with the tumor itself. In this patient, the medial cavernous wall pathology was sent, and it came back as positive for tumor infiltration. We're getting the last little bits of it here out, knowing that we're safe, knowing that the data suggests that taking the medial cavernous wall does not cause any long-term morbidity. Here you can see only gland is left around here. You have a little bit of bleeding from the cavernous sinus that's easily controlled. Again, flushing out all the blood products, just making sure that we get every last little bit of this out to make sure the patient has the best possible outcome. You can see that my partner, my ears and throat doctor, is using dynamic imaging. He's going in and out, his being my eyes for this case. We covered this defect up with normal nasal tissue that we harvested on the way in. That allows us to prevent postoperative fluid leaking from this area, as well as reconstruct part of the nose to help that nose heal. And so with the evolution of our endoscopic techniques, we've found that we have better optics to see things more around the area. With better optics and improved understanding of cavernous sinus anatomy, we're able to explore the cavernous sinus from a medial perspective. We know that we can resect the medial cavernous sinus wall that you saw there, and based on the holes that we're making, we're doing a better job of reconstructing these things to prevent postoperative complications. On top of this surgical technique, we are also improving our instruments, and so what we have now is we have 3D instruments that have really helped us to further visualize the pituitary gland, pituitary tumor. There are some tumors that we are able to use certain kinds of dyes to help see the tumors more clearly, which is certainly beneficial when you come to residual tumors and looking at where things are. We use cranial nerve monitoring during our cases so that we don't risk injury to cranial nerves that can cause double vision down the road, and obviously improving our ability to heal patients after surgery is as critical as the surgery itself. So what happens when surgery fails, and I think that's the kicker of all this, and I think that's an important part of this, is that we do have other options, and the other options revolve around medications, radiation, and finally we could take out the adrenal gland to decrease the amount of cortisol production, and which will decrease the symptoms that we're talking about when it comes to this. And I'll go into these a little bit more detail here. Medications are useful for managing things like prolactinoma. So we know that we can treat a prolactinoma tumor with medications and the patients can do better. So our thought process is if there's medications out there that can help these patients without doing surgeries, obviously that's the goal, but at this point we're not there. So what are our targets going to be for Cushing's disease and ACTH-creating tumors? There are 3 main targets that people talk about. One, we prevent people from making steroids, and so we give a medication that helps prevent this production of the cortisol. We can also give a medication that helps to block the cortisol when it gets to the sites that we're supposed to get to, so we block the receptors for the cortisol in the periphery. And then we also talk about corticotropic directed agents. Oftentimes, these medications are used in combination with other sorts of treatment modalities, especially in the setting when surgery won't work or has not worked in the past. Some of the medications that have been used and are more commonly used, ketoconazole, which is something that people are probably more familiar with. About half people can normalize their cortisol productions with it. The problem associated with ketoconazole is hepatic dysfunction, which can be terminal if it's not dealt with or prevented. Some of these other medications can also have some great effects, but they all have side effects or GI side effects or teratogenic effects that can cause problems. And these are all in the various states of being tested and used in the form of postoperative or treatments for Cushing's disease. Other medications, these are the corticotropic directed agents, and so these are the ones that bind to receptors on the adenoids themselves, and we found that they actually help to prevent the secretion of free cortisol down the road. There are side effects associated with this, and you can see that again, but these are all beneficial agents to help control the symptoms and signs of Cushing's disease. Carbergeline is one of those medications that we use a lot with prolactinomas. We found that there's some benefit in the use of Cushing's disease as well, especially in decreasing urine-free cortisol. Other medications, again, these are the receptors antagonists. These block the receptors that bind to cortisol, so it decreases the effect of cortisol. These often cause an increase in ACTH and cortisol production because the receptors for these are being blocked, which also blocks the negative feedback loop, and it blocks the peripheral effects of cortisol itself. There are associated side effects associated with these as well that are listed there, but in general, all three different mechanisms of action seem to have some benefit and sometimes can be significantly improve the patient's condition. Other options that can happen with other things we can use to help treat Cushing's disease is radiation and radiosurgery. When we talk about radiation, there's really two different modalities associated with this. Number one is treatment with something called stereotactic radiosurgery. Oftentimes is done in the form of gamma knife radiosurgery. This is a precise localization and use precise radiation to the site of the pituitary gland. The other the other treatment option is fractionated radiation. This is done over a series of days and weeks where you give a small dose every day to give an overall large volume. Control rates vary depending on where you read and what you ask. The problem with radiation is that it frequently causes hypopituitarism, usually over the course of 10 years, and increases over that. And people have described a cranial neuropathy associated with this because the radiation is addressing the pituitary gland and there are important nerves around that area. Those can sometimes be affected by radiation and cause a permanent neuropathy. Finally, if all else fails, bilateral adrenalectomies have been performed to remove the adrenal glands, to remove the production of cortisol levels. The problem with that is that the pituitary gland and pituitary tumor are still producing ACTH, and you can get a Nelson syndrome. Of course, you're going to get adrenal insufficiency if you're not producing any cortisol itself, and there's a mortality associated with the operation. And so those are important things to understand when it comes to these types of treatment options. One of the problems we have with Cushing's disease is that many medical options are available, however, few are FDA approved, and I think that's where I think we can make the most progress. Fortunately, 2 large phase 3 clinical drug trials recently were completed, and we're looking forward to seeing the results of those. And currently, there are multiple phase 2 drug trials that are currently enrolling. When it comes to treatment of patients with Cushing's disease, and it comes to a lot of surgical morbidity and mortality and problems with surgery, our goals as surgeons are to try to find ways to treat these diseases without doing surgery because we know there are risks, and we are all very excited about these trials that will help us in the armament of treating people with Cushing's disease and Cushing's syndrome. And with that, I'll stop. This is my references here, and I'll take questions if there are any.
Excellent. Thank you so much. A couple of questions. For the DD-AVP stim test, can you please explain the protocol? IV desmopressin, and what interval do you check the cortisol levels? Do you check ACTH with the cortisol? Yeah.
So great question. So our philosophy is to give it IV DD-AVP, and then we start checking 5, 10, 15, 20 minutes after that to determine whether or not there's an acute change in that. Again, we're checking peripheral levels, so sometimes it takes a little bit longer. So we check it up to an hour afterwards. Good question.
Okay, I have 2 pituitary tumors, approximately 3 centimeters each. What is your team's endocrinology threshold for determining whether the tumors are functional? Beside the symptoms, there has been a positive 24-hour urine. The patient is 20 years old.
Yeah. So it's a great question. I have a great team of endocrinologists here that help sort that out, are experts in that field. I think when it comes to whether or not these types of tumors are functional, if they do all the testing and it's come back marginally abnormal, we're not sure, and whether or not this is actually a patient with Cushing's disease, the next step is to do that IPSS, and that's been really helpful in specifically these types of situations.
Okay, is DD-AVP better than CRH to differentiate Cushing's disease from pseudo-Cushing's?
I don't think it's any better. I think we started using it when we had a hard time getting our hands on CRH, and so DD-AVP is more widely available, and so that's why we use it in these situations, but I don't think it's better or worse. I think it's just a matter of using it and availability.
Great, thank you. Does cabergoline shrink the ACTH-producing tumor like it does prolactinomas?
That's a great question, and I'm not sure we know the direct answer to that. That's not usually what we see with that. We usually just see the decreases in the actions. The problems, it doesn't shrink it as quickly as certainly as it does for prolactinomas, but my view is that the tumor will maintain the same size. We're just decreasing the amount of production that it's making.
Okay, great question. How common is Cushing's disease in adolescents?
It's relatively rare. I have to look up the exact percentages, but it's much more rare than the adult population. Again, I don't have right in front of me what the exact numbers are.
Okay, thank you. If a patient has significantly high ACTH, but their cortisol levels are normal, what would that indicate?
Either that the ACTH is non-functioning, so it could be an abnormal folding of the hormone itself so that it doesn't bind to the receptors on the adrenal glands themselves, or that the adrenal gland receptors aren't working right enough to get the stimulation that they're needed for the secretion of cortisol levels. And so it's one of those, either the hormone's not working or the receptor's not working, or there's something wrong with the adrenal glands themselves.
What treatment options are there for someone who had to have the pituitary gland removed with the tumor? Is a cortisone pump an option?
That's a better question for an endocrinologist, but I've not seen a cortisone pump because the natural daily cortisol in most people is ebbs and flows, and I have not seen cortisol pumps used for that purpose.
Okay, thank you.
That's a good question.
Can you review how you determine ectopic Cushing's versus Cushing's disease?
Yeah. So Cushing's disease is an entity that comes from the pituitary gland itself. And so, as we talked about at the beginning, separating Cushing's syndrome from Cushing's disease is a matter of the pituitary gland. Now, ectopic, I can pull back my slide too here. Ectopic secretion of ACTH will give you high levels of ACTH in the system. So on this slide here, you can see that when we find out whether or not there's levels of ACTH in the blood, then we start looking at the other kinds of tests, including the high-dose dexamethasone test, because that should secrete, so to decrease the amount of ACTH and cortisol in patients who have Cushing's disease. It would not do that in cases when patients have ectopic ACTH. Same thing with CRH. If we give a patient CRH, that should increase the amount of ACTH, but it should not. But it will not increase the amount of ACTH secreted from an ectopic source. And then finally, imaging was performed. And then finally, if that's not the case, the definitive answer is inferior petrosal sinus sampling.
Okay, thank you. Do you see a lot of silent aggressive tumors that cortisol levels stay good for long terms?
I'm not sure the exact question. What we do see is a lot of pituitary tumors that don't secrete cortisol, or don't secrete ACTH that go and produce the symptoms of this. We see a lot of pituitary tumors that are aggressive, again, that are not functional. I don't see many tumors that have. I don't see many tumors that are aggressive that do not secrete ACTH. that are Cushing's disease. So I guess I see patients who have small tumors that are secreting lots of ACTH and producing lots of symptoms. And I see lots of tumors that are fairly aggressive but don't secrete ACTH and may secrete other kinds of hormones or have other symptoms. But I have not seen, and I have seen some big tumors that have had mild elevations in cortisol levels and that came back positive for staining for ACTH. So tumors can be less aggressive and have mild symptoms on the patients, or they can be small and be very aggressive, but be small in size. I think the question is, do I see aggressive tumors that do not secrete ACTH that are positive? Aggressive tumors that produce mild symptoms, and in those situations, I would look for either that either the tumor is not making ACTH, or that the tumor may produce silent ACTH and not affecting the adrenal glands. I think that's what the answer he's looking for.
Is it feasible to maintain chronic therapy with ketoconazole in patients who refuse or are resistant to surgery and radiotherapy?
Well, I mean, it's a risk-benefit kind of ratio, and ketoconazole has its own black box warning, I think, just came out with the FDA. So there are risks associated with that. I think that the standard of care is surgery if possible to definitively cure this. I think as we get better at this in the future, I think we will have a medication that may be extremely helpful to treat these diseases without surgery. But I don't think at this point I would recommend that unless, like I said, he's failing other options or refuses other options and is willing to take those risks.
Okay, thank you. Intraoperatively, how do you identify the cavernous sinus medial wall tumor invasion, and how do you decide how big you need to resect the medial wall?
Yeah, so that's a really great question. So what we have found in the lab is that the medial cavernous sinus wall runs from the bottom of the sella to the actual carotid artery up top. So the carotid artery is attached to the medial wall, so I can't go any higher than that. When it comes to my resection technique, if I have a tumor that's touching the medial cavernous sinus wall, I'll take the medial cavernous sinus wall that is touching, and I'll take it back to where I'm confident that the tumor was not invading. What we find with these Cushing's disease is that it tends to essentially infiltrate the wall where it's in contact. It doesn't tend to spread out. When it comes to resection of them, any functional tumor that's in contact with the medial cavernous sinus wall, I'll resect the medial cavernous sinus wall.
Okay, thank you. In the pathology, do you always want to use crook hyaline changes, and if you don't, does that mean anything?
It's useful. It's a useful tool. So I think that's the thing. I think it's a better question for my pathologist to look at that. But from my perspective, those are the things that we're looking for any signs or symptoms that there is changes that may be consistent with a pituitary tumor. Doing frozen sections on pituitary adenomas is very, very hard. And so I'll defer to the pathologist to know if it comes to that kind of thing. But I'll look for anything in the pathology that indicates that we may be bitumor.
Thank you. Is there any indication for hypophysectomy in Cushing's disease?
Great question. Historically, that's been the case. So hypophysectomy is resection of the entire pituitary gland. When it comes to these types of things, I think that in patients who present with Cushing's, and we're talking about probably a microadenoma or small Cushing's tumor, our goal is to be as aggressive as needed for that. I think that if you're looking at a patient who has had a failed operation and you're talking about still not seeing where it's coming from, but your confidence coming from the pituitary source, I think that's a conversation we have with the patient saying, if I can't find it, I'm going to be as aggressive as I can to do that. That's certainly not an upfront option in my hands. I try to, again, preserve as much as I can. But once we start going down the options tree and we start realizing that finding, I think that's a conversation to have. the reason why that is because there are alternative treatments to surgery, and if we're going to cause hypopituitarism with surgery, there are others available that can help prevent that. That being said, in cases where it's necessary because they've failed other options or failed other treatments, or if we're doing an adrenalectomy and the pituitary gland is still causing increases level of ACTH, and I have a patient right now who had an adrenalectomy or had a pituitary tumor resected, did not have any impression of the cortisol level, then had adrenalectomies, and ended up having a small nest of the adrenal gland left over, and the pituitary gland was still making ACTH, and the tumor was still making ACTH, and now she has a tumor in the pituitary gland that's more visible because of time and persistence. I think in those situations, you know, you can't get the whole thing and she's having symptoms because of it. I think that hypoxectomy may be warranted, but that's a case-by-case basis. I don't think I can say that. Thanks, Steve.
Great, thank you. So I was surgically cured a while ago, 15 years. Now that I am aging, what extra problems are associated with having had Cushing's for a significant period of time in my past?
One second, can you repeat that one more time?
So surgically cured a while ago, 15 years. Now that I am aging, what extra problems are associated with having had Cushing's for a significant period of time in my past?
I think that goes back to what sort of problems are you as a result of the long-term Cushing's. I think, you know, the result of cortisol, and like I said, we all need it, and if you're cured of that disease and you're not showing any signs of recurrence, which is great, especially 15 years out, I think that I would not look for anything specific. And if a lot of the disease entities that you were suffering from before, if they've reversed course, then I would not change anything that you're doing or look for anything different. The things that I'd be worried about for disease recurrence are things, you know, that led to the diagnosis in the first place. And what we have found is that once we've taken care of that problem, the high blood pressure and it goes down, and the diabetes gets better, a lot of those problems are nothing that we need to look for specifically associated with that.
Okay, can you review how you do the high-dose dexamethasone suppression test?
Yeah, so this is a test that's mostly run by our endocrinologist, and so I don't have the exact data in front of me for their protocols for that, but in general, we give 8 milligrams of dexamethasone, and then we at night, and then we check the cortisols the next morning to determine what we're at.
Okay, when do you recommend reoperate Cushing's disease in case of surgical failure? Immediately after or after a few months?
So that's a great question too. So it kind of depends on the situation that we find ourselves in. So I get about half of my practice is redo pituitary cases. So patients have had surgery elsewhere, and then they present with residual disease or symptoms. In those cases, if I think I have a target on the imaging, I will pursue surgery at that point, which is oftentimes months later. If I have a patient that we did surgery on after 48 hours, their cortisol levels have not dipped to a appreciable level where I think that there might be leftover tumor, I would at that point re-image them in the form of an MRI. And then if I see that there's maybe something there, or if I think that there might be something there based on intraoperative findings or their cortisol levels, I will take them back to that hospitalization. So when you're doing surgery, the best time to fix a problem right away, because everything is still open and not scarred. And when you go back in later, there's a lot of scarring that can lead to hard time finding the tumor, and you put the pituitary gland and the nerves and carotid artery at greater risk just because of the scar that's there.
Okay, thank you. If the initial surgery produced an incidental tumor, but the Cushing's disease still exists, is the second surgery out of the question? Thank you.
Not out of the question. So the question then becomes what is the source? And if you took out an incidental tumor and the source is still a pituitary gland, that means they probably had 2 pituitary tumors, which is extremely rare but not unheard of, because if the source is there, then I would say that surgery is still indicated to try to find it if you didn't get it the first time.
How available are MRIs that are better than Tesla 1.5, and should we always use this with a Cushing's disease patient?
So 3 Tesla MRIs are widely available. More than that, you're looking at 7 Tesla, that's more of an experimental approach, and so those are only at certain facilities where we can look at that. I would not say that routine imaging with higher degree, higher Tesla MRIs is necessarily warranted. I think that when it comes to 1.5 versus 3, there are subtle differences, but I think if you don't see it on the 1.5, you may have a hard time seeing on the 3, and then further ancillary studies in the form of like IPSS may be warranted at that situations if you don't see anything.
Okay. When a 9% mortality rate with adrenalectomy was mentioned, at what point does that occur? During surgery or post-op?
That's post-op, and again, that's one series that I read that I thought that was relatively high. But the important thing is that that nothing we do is benign, and that when we're doing adrenalectomy type surgery, we're taking away the body's response to ability to respond to a crisis, and that's what surgery is a crisis. And so often these people are treated during surgery, but at the same time, they didn't go into the details specifically of why the mortality rate was that high. But I think they reported it as such because it was within the 90-day window.
Okay. What is the best test to monitor Cushing's disease activity following surgery? Urine-free cortisol, DEX suppression, or nocturnal cortisol?
We like to do salivary cortisols, because they're easy. You can do a bunch of them, and that's how we like to routinely monitor those kind of things. Certainly, long-term monitoring, you can do those other kinds of tests, urine-free cortisol and whatnot. But we frequently will use salivary cortisols for long-term monitoring.
Okay. Is there any changes in the tumor consistency intraoperatively after long-term medical therapy?
So this is a great question, and I've seen it a few times. I have not seen any changes that come because of medical therapy from these types of tumors. Unlike other types of tumors that may be co-secreting, so like a tumor that secretes prolactin or growth hormone, when they're given medical therapy and they don't respond, or the growth hormone continues to be high and they require surgery, those tumors tend to be more firm than their counterparts who haven't been treated. But I have not noticed that in patients who have undergone medical therapy with Cushing. That's a great question.
Okay, and how can we find out about the phase 2 trials that you mentioned?
I think the first place you can start is with the endocrinologist that you see, and they can do referrals to different centers to get you involved through that avenue. That's usually the easiest for patients to get involved.
I think that concludes our questions so far. Anybody who has questions, get them in now. Yeah, it looks like I don't see any more. So we'll go ahead and end here. Excellent information. Thank you so much, and excellent questions as well. Thank you so much for doing this presentation and for answering all these questions. This concludes today's webinar presentation. We appreciate you all taking the time to join us. If you missed any part of this webinar, we did record it. It will be available on our website after it's edited. There will be a brief survey after. Please fill it out to help us get you the information that you need. Thank you for joining us all, and we're getting some thank yous popping up as well. Thank you very much. Excellent presentation. Thank you, thank you. So we all appreciate you taking your time out of your busy schedule to help us all. And everybody have a great day.
Thank you, guys. Thank you very much. My pleasure.
Thank you.